Hello everybody, my name is Dr. Behrad Baharlo. I'm a consultant in intensive care medicine and anaesthesia at Hammersmith Hospital in London, which is this institution that you can see pictured on the top right-hand side of my slides. I'm also a Honorary Clinical Senior Lecturer at Imperial College London, and it is with great pleasure and a privilege that I join you today at the British-Ukrainian Symposium on Anaesthesia, Intensive Care and Paramedicine. My only regret, obviously, being that I cannot join you in person in Kiev. I will be talking to you today on renal replacement therapy in critical illness, and specifically revisiting the seminal STAART-AKI trial that was published in 2020, which was essentially a practice-changing trial, which really did answer the question around timing of initiation of renal replacement therapy within the critical care setting. So for the purposes of this talk, our learning objectives are going to be as follows. We'll initially start by talking a little bit about the dilemma as it stood at the time that this trial was recruiting, and subsequently reported and published in 2020, particularly around the uncertainties around the timing and initiation of renal replacement therapy in patients with severe acute kidney injury, so AKI, in the critically ill population. Specific to this trial, we'll speak a little bit about how the trial was set up, its methodology and its interventions. And then finally, we will talk a little bit about the clinical impact, in particular to daily ICU and anaesthesia practice, and ultimately the take-home message of the trial. And here it is, the STAART-AKI trial, published as an original article in the New Journal of Medicine in July 2020, entitled "The Timing of Initiation of Renal Replacement Therapy in Acute Kidney Injury," on behalf of the STAART-AKI investigators, predominantly led by Ron Ward and Sean Bagshaw, who led the main trial steering committee out of Canada. I was privileged to be involved as a STAART-AKI co-investigator in one of the trial sites at the time. But before we go on to talk about the trial itself and present the trial data and results, it's worthwhile just recapping a little bit about the concept of acute kidney injury, particularly in the ICU. Now, AKI itself is very commonplace, and it occurs in anything up to about 20% of hospitalised patients, so inpatient hospital admissions. However, it is also a very common complication in the critically ill population as well, and its prevalence is anything up to about 60% of the critical care cohorts, typically being caused by episodes of sepsis, cardiogenic shock, or the administration of nephrotoxic medications and drugs. It is associated with a significant mortality and also major comorbidities as well, and typically can develop into end-stage renal failure. And we think that about 10 to 30% of patients who develop an AKI in the context of critical illness will require some sort of long-term renal replacement therapy should they survive their critical illness. As such, AKI has significant impacts on cost and resource utilisation on the wider health service. And we know that in the UK public health care service, each episode of AKI in hospitalised patients typically costs the healthcare provider in the region of anything between £5,000 and £8,000 per episode per patient. And largely this cost is borne out of increased length of stay both in hospital, but also critical care admissions and ancillary costs to include critical care length of stay, but also the initiation of replacement therapy. Overall, the cost to the NHS itself is significant. The GRIPT document that was published for the identification of AKI in the UK suggests that acute kidney injuries cost the NHS anything up to £1 billion per year, across the entire health service, making up about 1% of its budget. And should you be lucky to survive more critical care episodes and associated AKI, many of these patients will require ongoing replacement therapy. typically by way of community intensive dialysis. And this obviously has a significant expense to the wider health service, notwithstanding the need for renal transplantation. Now, going back to around 2015, 2016, when the STAART-AKI trial began recruiting, but also when some other trials, namely Elaine and Kiki, were reporting, the question around the timing of initiation renal replacement therapy in the critical care population remains unanswered, and it remained unanswered in view of some conflicting evidence that was reported at the time. Now, advocates of initiating renal replacement therapy early in the critical care episode suggested that there are potential benefits, and they pointed to the benefits of restoring homeostasis, preventing any metabolic complications, mitigating for fluid overload and fluid accumulation, and the benefits of early clearance of urine toxins as being reasons why we may want to start renal replacement therapy sooner rather than later. However, those who thought to the contrary pointed to the risks associated with unnecessary early renal replacement therapy, not just limited to the concept that is associated with catheter-related complications, so vascular access complications, the hemodynamic instability that ensues as a result of bestowing a patient's cardiovascular state onto an extracorporeal circuit. But also they pointed to the potential for denying an opportunity for spontaneous recovery, and notwithstanding that, whether there may be a risk that starting renal replacement therapy may potentially cause a risk of dependence on renal replacement therapy and a cause for instant renal failure. Now, as I mentioned, the question around the timing for initiation of renal replacement therapy in the critically ill population was at the time actually informed by three different trials, which actually gave conflicting net conclusions. And these were essentially the Elaine trial, which was a single centre German trial of predominantly surgical ICU patients, which actually favoured the initiation of renal replacement therapy early in respect to its primary outcome of 90-day mortality. But this was then opposed by two separate French trials, the Kiki trial and the Ideal ICU trial, which showed no difference in 60-day mortality in the Kiki trial, and actually the Ideal ICU trial was actually stopped early because it demonstrated no benefit of early renal replacement therapy. So the rationale really for the STAART-AKI trial was that a large multinational randomized controlled trial was needed, in essence, to resolve the conflicting evidence as it stood at the time. So the STAART-AKI trial's objectives were to determine whether an accelerated strategy for renal replacement therapy in critically ill patients with severe AKI, as defined by the KDIGO classification, results in a lower risk of death at 90 days compared to a standard strategy. And the primary hypothesis here was that the accelerated strategy was superior. Now, how was the trial designed? Well, the trial was a multinational trial, and it involved 15 countries. It's involved 168 different institutions across those 15 countries. It was a randomized control trial, open label, which ultimately randomized 3,019 patients in a 1-to-1 ratio between October 2015 and September 2019. Its primary outcome, as I've already suggested, was all-cause mortality at 90 days, and it was powered at 90% to find a 6% absolute difference based on a 90-day mortality of 40% in the standard arm. So essentially, an anticipated 90-day mortality of 40%. The trial's main inclusion criteria was that it's essentially included all adults over the age of 18 admitted into the intensive care unit. The baseline creatinine of over 100 micromoles per litre in women and over 130 micromoles per litre in men. It developed a severe AKI as defined by the KDIGO classifications of stage 2 or stage 3 criteria needed to have been reached within the study window. And KDIGO stage 2 or 3 defines AKI as a twofold increase in creatinine or urine output of less than 6 mL per kilo over 12 hours. Now, the main exclusions from the trial were as follows. So any emergency indication for renal replacement therapy, so these being the standard emergent indications for the initiation of renal replacement therapy, like hyperkalemia, profound acidemia, uremia, complications of uremia thereof, or fluid overload. Advanced CKD is defined by an eGFR of less than 15. If the patient had succumbed to any sort of poisoning or overdose of dialyzable toxins, they were excluded. Patients who have had renal replacement therapy within the previous 90 days, patients who have had a kidney transplant within a year, or patients who were expected to recover their renal function. Now, a hallmark of the trial was around the concept of a subjective component, which required the use of clinician judgment to exclude patients that were likely to recover renal function, or those that needed urgent commencement of renal replacement therapy. And this subjective component, being a hallmark of the conduct of the trial, ensured a real-world pragmatic approach to the randomization of patients. So such that for a patient to be randomized, they needed to fulfill the inclusion criteria, notwithstanding the exclusions. And the clinician at the bedside looking after the patient had to have real clinical equipoise between commencing the replacement therapy as an intervention for the AKI, or proceeding with pharmacotherapy or a watch-and-wait strategy. As such, for clinical equipoise to have been met, the attending physician had to affirm the absence of a mandate for immediate start or immediate deferral based on clinical recovery. And this ensured that only patients with a genuine uncertainty around whether to start or delay renal replacement therapy were ultimately randomized. Once all inclusions and no exclusion criteria were met, the patient was randomized to the trial, providing that there was true clinician equipoise. And it should be noted that over 7,000 patients were excluded at this point due to a lack of such clinical equipoise. Randomization of patients occurred in a 1-to-1 ratio into an accelerated strategy arm, where renal replacement therapy was initiated as soon as possible, or certainly within 12 hours, with the primary goal being the preemptive correction of AKI metabolites. It should be noted here that in those patients who were randomized into the accelerated strategy arm, renal replacement therapy was actually delivered to about 97% of these patients. Conversely, patients were otherwise randomized into a standard strategy arm, where the initiation of renal replacement therapy was discouraged unless the conventional indications were to develop. And the indications for a start to renal replacement therapy in the standard strategy arm was a potassium of over 6 millimoles per litre, acidemia is defined by pH of less than 7.2, or a bicarb of less than 12 millimoles per litre, or the persistence of such AKI for over 72 hours. Now, the thing to note here is that the delivery of renal replacement therapy in the standard strategy arm was 61.8%, meaning that about 38.2% of patients in this standard arm never actually received renal replacement therapy. The fact that nearly 4 out of 10 patients never actually received renal replacement therapy in the standard strategy arm, either because their renal function had actually recovered or they had died, is a significant finding we will come back to later in the report. Baseline characteristics for the entire population that was recruited into the trial had a mean age of 64.6 years. Those patients who had an underlying cause of sepsis accounted for 57.7% of the total population. Severity of illness scores, the mean SAPS-2 score was 58.8, and about 77% of the entire population required mechanical ventilatory support. Characteristics were very well balanced across both arms of the intervention in age, female sex, chronic kidney disease, sepsis, septic shock, mechanical ventilation, severity of illness scores, and serum creatinine at the time of randomization. So did the trial do what it set out to in respect to the delivery of renal replacement therapy and its timing? Well, yes, it did. So the accelerated group, median time to commencement of renal replacement therapy was reported as 6.1 hours against a median of 31.1 hours in the standards arm. And as such, the trial managed to achieve a 25-hour separation in respect to timing of initiation of renal replacement therapy between these groups, as a result providing a relatively robust test of the primary hypothesis. And this gap, if you like, between the early and standard group is very consistent with the previously aforementioned trials, which typically sought a time to initiation of renal replacement therapy in their standard or delayed arms of over 25 hours. And so of the results, so of the 1,465 patients that were randomized into the accelerated strategy, 633 or 43.9% died within 90 days. And conversely, those in the standard strategy, 639 out of the 1,462 patients in that arm died, and as such, giving a 90-day mortality of 43.7%. Relative risk was reported as 1 with a 95% confidence interval of 0.93 to 1.09, which obviously crosses 1 with a p-value of 0.92. So there was no difference whatsoever, as you can see, in 90-day mortality between the accelerated arm versus the standard strategy arm of the trial. And you can see that the Kaplan-Meier curve here depicts exactly that, where the 90-day survival of Kaplan-Meier curves show overlapping curves, confirming no difference in mortality. So the trial also looked at a number of secondary outcomes. It looked at dependence on renal replacement therapy at 90 days. It looked at composites of all-cause mortality and renal replacement dependence at 90 days, major adverse kidney events, so composite of death, renal replacement therapy, dependence or sustained reduction in kidney function. It looked at eGFR at day 90, albuminuria at day 90, mortality in ICU on day 28, renal replacement free days at day 90, and mechanical ventilation free days at day 28, as well as vasoactive therapy free days at day 28 as secondary outcomes. Now, the main takeaway key secondary outcome signal is as follows. So the concept of long-term harm and renal replacement dependence was found that in the accelerated group, 10.4% of patients who underwent renal replacement therapy in the accelerated group were still requiring renal replacement therapy with dialysis at 90 days, compared to 6% of those patients who underwent renal replacement therapy in the standard group. So survivors in the accelerated arm were 74% more likely to remain dependent on dialysis at 90 days, with a relative risk of 1.74, a confidence interval of 1.24 to 2.43. And this suggestion is really key in regards to practice change, because it suggests that early renal replacement therapy in the critical care population may potentially impede, possibly, endogenous kidney recovery, but certainly points towards a risk for long-term renal replacement therapy and dialysis dependence. Now, I mentioned earlier that 38.2%, or about 4 out of 10 patients randomized into the standard group, who never actually received or needed renal replacement therapy, either because of kidney recovery, kidney function recovery, or unfortunately death. And that 97% of patients in the accelerated group did receive renal replacement therapy as per the protocol. And this concept really, and these results really, when taken together with the fact that at randomization, the groups were largely similar in respect to mean creatinine, as well as the number of ICU days during their critical illness and trial randomization, suggests that whilst the two groups at randomization were very similar in nature, the fact that 4 out of 10 in the standard group did not receive renal replacement therapy may in some ways be protective against the secondary outcome of renal replacement dependence at 90 days. As such, you can suggest that this is a strong indication that watchful waiting is safe and potentially superior in the concept of AKI, particularly for renal recovery. This slide confirms or illustrates the suggestion of harm in survivors randomized into the accelerated group when it comes to the secondary outcome of renal replacement dependence at 90 days. There's a possible inference of an increase in rehospitalizations at 90 days in the accelerated group as well, but thereafter none of the other secondary outcomes showed any statistical difference between the accelerated or standard arms. The further takeaway of the trial results was that in relation to adverse events and safety, the trial found that total adverse events were significantly more frequent in the accelerated strategy group, to 23% versus 16.5% in the standard group. And in particular, the adverse events of hypertension and hypophosphatemia were significantly higher and statistically significantly higher in the accelerated group versus the standard structured group. Whilst total adverse events were significantly more in the accelerated structured group, the risk of serious untoward events was not shown to be significantly different between the two groups. Subgroup analysis also suggests that the findings were pretty robust across 6 pre-specified subgroups, showing no heterogeneity of the treatment effect. And these groups were analysed according to sex, baseline GFR, so less than 45 and above 45, the presence or absence of sepsis, severity of critical illness, with, as delineated by SAP score of over 58 or less than equal to 58, admission types being surgical versus medical and geographic region. So no specific population benefited from an accelerated start. And this is the forest box plot that confirms that there was no significant heterogeneity of treatment effects across the pre-specified subgroups that were looked into. So what do we think of the trial's strengths and limitations? Well, it's widely rehearsed that the strengths lay in its large sample size, recruiting over 3,000 people into the trial, and it was adequately powered to detect the 15% relative risk or 6% absolute difference. It's multinational, involving 168 centres in 15 countries, so it's broadly generalisable. Its novel use of the clinical equipoise to guide eligibility was real-world pragmatism, and with robust blinding of outcome assessors and central adjudication. It benefited from comprehensive pre-specified secondary outcomes, including quality of life, and 97% of follow-up in modified intention to treat analysis, so there was very low attrition rates. It was, however, limited by the fact that it is an open labels design, so the clinician's behaviour may have been influenced by knowing which arm the patient was randomised into. Clearly, clinical equipoise is subjective, so selection variability between the sites, depending on local practices, may have influenced the concept of equipoise. There was also broad clinician discretion in the standard arm, so there was variable initiation timings. And then we've also said that 38% of standard group never actually received renal replacement therapy, so this could possibly lead to a bit of selection bias. Adverse events were partly attributable to greater renal replacement therapy, and long-term outcomes over 90 days were not ultimately assessed. So what does this mean to us in our clinical practice? So the takeaway messages are that there is no benefit from the early initiation of renal replacement therapy. Standard strategy is safe, and so in using a standard strategy, we can use conventional triggers like hyperkalemia, acidosis, volume overload, and persistent AKI, particularly over 72 hours, but probably not more than 5 days to guide renal replacement therapy initiation as per KDIGO. The risk of renal replacement dependence is there. Clearly, an earlier renal replacement therapy strategy significantly increases dialysis dependence at 90 days. And this may be a reflection of the loss of an opportunity to recover endogenous renal function. But clearly, it's greater harm with an accelerated strategy with increase in hypertension and hypophosphatemia. So as a result, we really should be looking at shared decision making as a key determinant, utilising patient-specific factors like presence or absence of CKD, surgical risk, frailty, in regards to informing our timing. And finally, quality of life was preserved irrespective, so there's no difference in quality of life, frailty or organ-free day survival between the two groups. So there is no mortality benefit in starting renal replacement therapy early, and then early start does have the potential for harm in respect to hypertension and an increase in renal replacement dependence. But notably, spontaneous recovery can occur, and approximately 38% of patients with severe AKI recover without renal replacement therapy if given time. So watchful waiting is indeed safe. Thank you very much for your attendance and your attention, and I do very much hope that I can join you online to answer any questions.